listen to you should always be putting it forth so that Dr. Ashish and his team can take forth your concerns as well. So we have diverse topics ranging from radiology to radiation to imaging to cardiology to
to splinter, when we want to preserve it, when we don't want to preserve it, and how to do that, and how to achieve a good function. So first and foremost is adequate imaging for rectal cancer. So I'll invite Dr. Simi Vats, who is the DNB radiodiagnosis candidate at JP Hospital, Noida, to make a short presentation on that. And I also welcome Dr. Parul Garg, Associate Director, Radiodiagnosis, and Dr. Shikha Pawar, who is the Director of Imaging at Mahajan Imaging, as moderator as well as the mentors. But over to you, Dr. Simi.
Thank you so much, sir. Sir, is my presentation visible?
Yes, you need to make it full screen.
Slideshow.
Yes, sir. Okay, sir. Good evening, everyone. I am Dr. Simi Vats, DNB Radiodiagnosis from JP Hospital, Noida. So today we are here to discuss imaging in rectal carcinoma from the clinician's perspective. That what does the clinician wants? So beginning with the importance of MRI, rectal MRI, it plays a key role in the pre as well as in the post-treatment evaluation of rectal cancer. So in pre-operative long course chemoradiotherapy, it provides 5-year loco-regional recurrence rate compared with post-operative long course chemoradiotherapy in stage mainly T3, T4 or not positive patients with less toxicity. So there must be a technique which identify the prognostic factors pre-operatively so that we can decide which patient we have to treat locally for total mesorectal excision and for which patient we have to go for preoperative RT or CT. So MRI, it helps in differentiating the prognostic factors preoperatively, which help in differentiating the low-grade tumors from the locally advanced or metastatic tumors for which neoadjuvant chemoradiotherapy is indicated. So rectal MRI protocol, we have to do high resolution T2 weighted imaging with phased array external surface coil MRI, either 1.5 Tesla or 3 Tesla without fat suppression. So we will take the images in all the three planes, sagittal, axial, as well as coronal. So first series will be sagittal along the longitudinal axis of the tumor from one pelvic side wall to another, which locates the tumor and gives its relation to the peritoneal reflection. Secondly, we will take axial sections perpendicular to the tumor for better T-staging of the tumor. Then coronal plane, which is parallel to the anal canal. And this is mainly important in low rectal cancers for the involvement of levator ani muscles, sphincter complex, and the intersphincteric plane. Then these all sequence were small FOV sequences. Then we have to take a large FOV axial sequence also of the whole pelvis from the aortic bifurcation up to the anal verge to see for the distant lymph node status. Then these are some of the conditions that we can use while doing the rectal MRI protocol. We can give rectal gel or enema to mildly distend the rectum in case of small tumors, small polypoidal tumors. But it should not be distended much as it can alter the morphology of tumor and its relation with the mesorectal fascia. Then the referring surgeon should accurately communicate the tumor position for appropriate coil placement and planning of the sequences. So beforehand, we have to know if the tumor is low, mid, or high rectal based on the sigmoidoscopy done by the surgeon, so that we can appropriately place the coil in that area only, and we can plan the sequences what we need to do. So then diffusion sequences. Diffusion sequences has a role in to see the extramural venous invasion and in the localization of lymph nodes and in checking the response after CRT. That is in restaging, we have the role of diffusion weighted imaging. So before starting the MRI approach, we first see the MRI anatomy of the lower rectum mainly. So mesorectal fascia, it is the mesorectal fascia is mainly we are concerned about mesorectal fascia in case of low rectal tumors, which is the standard surgical approach done in total mesorectal excision, in which mesorectal fat and mesorectal fascia is excised. So in this case, you can see this is the mesorectal fat, and this red line, it is representing the mesorectal fascia. So in case of high and mid tumors, mainly in mid rectal tumors, we are concerned with mesorectal fascia. It is a best. Uh, so in case of mid tumors, the mesorectal fascia is completely surrounding the rectum. So it is the best plane for excision. So as we come down to low rectal tumors, there is a thinning of the mesorectal fascia. As you can see here, we can see there is thickness of the mesorectal fat, and here we can see the thickness of mesorectal fat. So as we come to the low rectal tumors, the thickness of the mesorectal fat decreases, and we are mainly concerned about the anal sphincter complex here. So I have given this systematic approach to the interpretation of MR images in the form of a mnemonic distance. So first of all, dis from the distance, first word, first letter, it stands for the distance from the inferior part of tumor to the transitional skin. That is we have to give the level of tumor from the anal verge. So we have divided the rectal tumors into low, mid, and high based on the distance from the transitional skin. So 0 to 5 centimeter are considered as low rectal tumors, 5 to 10 centimeter are considered as mid, and above 10 centimeters are considered as high rectal tumors. So in upper rectal tumors, we are mainly concerned about the peritoneal reflection, which comes here at the level of cul-de-sac in case of females and above the level of just seminal vesicle in case of males. So in high rectal tumors, we have to especially see about the peritoneal reflection so that the surgeon can avoid the peritoneal spillage of the tumor during the surgery. In case of mid-rectal tumors, I have already told that we are mainly concerned about the mesorectal fascia. And in case of low rectal tumors, the mesorectal fascia, it is thinned out, and we are mainly concerned about the sphincter complex, intersphincteric plane, and the puborectalis sling. And here also we can see the MR images of the low, mid, and the high rectal tumors. So we have also we have to also tell the clock position of the tumor, and we can tell if it is polypoidal, circular, or circumferential. And we can also tell on T2 weighted images that if the tumor is mucinous or non-mucinous. Mucinous tumors have high signal intensity on T2, and the non-mucinous tumors have the intermediate signal intensity. Mucinous tumors have worse prognosis. So we can also tell about the mucinous or non-mucinous content of the tumor. Then here we can see this is for mainly for low rectal tumors. As we come downwards, the mesorectal fat is thinned out, and it continues at the continues as the intersphincteric space. This is the internal sphincter, external sphincter, and this is the anal verge. Coming on to the second letter of the mnemonic distance, T. T stands for the tumor. So first of all, we will see the T staging of the rectal cancer. So in case of T0, there is no evidence of primary tumor. Starting from T1, T1 tumor, it is limited up to the submucosa, but does not extend into the circular muscular layer. Then T2, it invades the muscularis propria layer, but does not penetrate it. T3 tumors, they invade the subserosa through the muscularis propria layer, and then we have to divide it T3 into T3A, B, C, and D according to the spread of the tumor. Less than 1 mm, 1 to 5 mm, 5 to 15 mm, and beyond 15 mm in the mesorectal fascia. So in T3 tumors, we have to say if MRF positivity is there or MRF negativity is there. In case of T4 tumors, T4A is for peritoneal reflection if the tumor is invading the anterior peritoneal reflection, and T4B is for other organs like anteriorly prostate, urinary bladder, and all these all organs are involved or not. So coming back to the T staging, T1, as we discussed, T1 rectal carcinoma are confined to mucosa and submucosa. T2 tumors invade the muscularis propria, and T3 lesions, they extend beyond the muscularis propria into the mesorectal fat. So main factor we have to tell that the depth of extramural spread. It is the key factor in determining the prognosis and stratifying the patient for preoperative therapy. So we have to tell the depth of extramural spread in millimeters. So to decide how much spread is there in mesorectal fat, and accordingly which we can plan the preoperative therapy of the patient. So T2 tumors that are limited up to the muscularis propria, they have exactly same prognosis as T3 tumors which are less than 1 mm spread, which have not spread into the mesorectal fascia. They almost have same prognosis. Then T3 tumors which has spread of 5 mm or less, that is up to T3 B stage, they have a survival rate exceeding 85%. Then T3 tumors which are beyond 5 mm, that is T3C and beyond, they have high mesorectal invasion risk and they have a survival rate of approximately 54%. So these are some of the examples of the T staging. These are the three layers: mucosa, submucosa, and muscularis propria. So in this case, we can see the muscularis propria is intact. So this is a case of T1 tumor. Then coming on to the T3 subdivisions. So here we can see there is minimal invasion of the mesorectal fat. We can say less than 1 mm. So this comes in T3A, then 1 to 5 mm T3B, then more than 5 mm T3C and T3D. Then in the T3 stage, we have also have to comment on the invasion into the mesorectal fat. So if the margin between the tumor and the mesorectal fat is less than 1 mm, then we will give that it is involved. So in that case, neoadjuvant chemoradiotherapy is indicated. In this case, we can see mesorectal fascia is intact. And in this case, there is the involvement of mesorectal fascia by the tumor. Then this is an example of T4B stage, that is invasion of the surrounding structures. In the first image, we can see the tumor is anteriorly invading the prostate and the bladder. And in this case, we can see the tumor is involving the levatorani muscles on the left side. Coming on to the peritoneal reflection importance in case of upper rectal tumors, mainly, we can see this is the peritoneal reflection layer seen on the sagittal MRI images. And on axial images, we can see it looks like a seagull sign or V sign. The pitfalls of MRI in T staging. So we have some of the pitfalls that it is difficult to distinguish T1 from T2 tumors. So as we already discussed, there are three layers: mucosa, submucosa, and muscularis propria. So in the absence of submucosal edema, the rectal wall, we generally see two-layered appearance of rectal wall in case of on MRI. So we cannot properly recognize muscularis propria distinguishing from mucosa and submucosa. In that case, endorectal ultrasound is more accurate. Then another pitfall is differentiation between T2 and borderline T3 lesions. So T2, which is limited up to the muscularis propria, and borderline T3 means less than 1 mm invasion of the mesorectal fat. Sometimes these are also difficult to differentiate. Then another one is difficulty in distinguishing true mesorectal invasion in case of T3 from desmoplastic perirectal stranding in T1, T2 tumors. Sometimes the tumor is limited only up to the muscularis propria, but there is desmoplastic perirectal fat stranding, which looks like that the mesorectal fascia is being invaded, but some points are there to differentiate between them. If there are fine strands are there, then it is most likely desmoplastic reaction. And if there is nodular thickening, then most likely it is the true invasion of mesorectum by the tumor. Then another pitfall is the distinguishing between T3 and T4A lesions owing to the peritoneal invasions. So the identification of peritoneal attachment and its involvement is very important, because tumors with peritoneal reflection invasion, they comes in T4A category, and they also require preoperative radiation therapy. Then coming on to the fourth letter, that is from the distance mnemonic, anal complex involvement, sphincters and the puborectalis muscle status. So this is the main importance we have in the case of low rectal tumors. So if anal complex or sphincters are involved, they have the higher rate of positive resection margins after surgery, higher local recurrence rate are there, poorer survival of the patient. This is largely due to the anatomic variation. We studied that coming from mid to low rectum, the mesorectal envelope tapers downward. So we have to see the pre-treatment MR imaging must be able to allow us to define the location of tumor relative to the sphincter complex, to propose which patient need to receive CRT before surgery, and to decide the type of surgery, if we have to do low anterior dissection or abdominoperineal or extra-levator approach. So accordingly that the surgeon will decide the type of surgery. So there is a separate staging for anal sphincter complex involvement in case of low rectal tumors. So stage 1 is tumor is confined to bowel wall and intact outer muscular coat. So only the bowel wall is involved and the outer internal sphincter is intact. In stage 2, the tumor replaces the muscle coat but does not extend into the intersphincteric plane. It is completely involving the internal sphincter, but the intersphincteric plane is maintained. In stage 3, the tumor invades the intersphincteric plane also and lies within 1 mm of the levator ani muscle. This is the levator ani muscle. In stage 4, the tumor invades the external anal sphincter also and is within 1 mm and beyond the levator ani, with or without the involvement of the adjacent organ also. So based on that anal sphincter involvement, there are various variants of the surgery that can be done in case of low rectal tumors. So total mesorectal excision, it is a total resection of the mesorectum along with the mesorectal fascia done in the case of local tumors, not in case of advanced tumors. So in case of low anterior resection, in case of LAR, the anal canal is left in situ. It is typically done for middle and upper rectal tumors so that the sigmoid and the lower end of the rectum can be attached.
इसमें ना मुझे आशीष गोयल ने कहा था कि अगर कोई पैनल मिसिंग होगा ना तो आपको करना पड़ेगा.
So we have to another 2 minutes.
Yes. Shall I continue, sir?
Yeah, another 2 minutes.
Okay, sir. So abdominal perineal section surgery. In this case, the rectum and anal canal, they both are resected and blocked, and patient receive a permanent colostomy. It is indicated mainly for low rectal tumors with involvement of the anal sphincter complex. Intersphincteric APR, it is a variation of the standard APR, where if the external sphincter is spared, then we can go through the intersphincteric plane. Then extra-levator APR, it is extensive approach which includes the excision of levator ani muscle also, and it is done for those cases in which the levator ani is completely involved with the involvement of the adjacent organs also. And local resection, it is mainly for the T1 and T2 tumors, which are polypoidal. So this is the diagram of the different surgical techniques that can be performed for low rectal tumors. Low anterior resection can be done, APR can be done, then we can go through intersphincteric plane also, and this is for the extra-levator approach. So preoperative benefit of preoperative chemoradiotherapy is that it can convert the locally advanced low rectal tumors into the low grade tumors, so that the surgery which earlier was required, like abdominal perineal resection, it can be downgraded. Coming on to the nodal staging, the end part of the distance approach, nodal staging. So main criteria are, if the node is less than 10 mm and they are homogeneous signal intensity, then they are not suspicious. If more than 10 mm heterogeneous, then they are suspicious. Then nodes with irregular borders, mixed signal intensity, they are considered to be suspicious. Then this is the importance that the level of highest suspicious lymph node should be mentioned in the MRI report to decide the field of radiotherapy. And if any lymph node is within the 1 mm of the circumferential resection margin, it must be reported because it is highly suspicious of CRM involvement. And this is the N staging. N1A, there is only one suspicious lymph node. N1B, 2 to 3 lymph nodes are there. In N1C, there is no regional lymph nodes, but there are presence of tumor deposits. In N2A, there are 4 to 6, and in N2B, 7 or more suspicious regional lymph nodes are there. So in case of regional lymph nodes, there are mesorectal lymph nodes, which are standardly excised in case of TME. Then comes the rectalis superior and inferior mesenteric lymph nodes that are excised only in case of high rectal tumors. Then there are extra mesorectal or lateral lymph nodes that are internal iliac and obturator lymph nodes. They have the size criteria of 7 mm. Above 7 mm, they are considered as suspicious. Normally, the regional lymph nodes that are included in end stage, we are having more than 10 mm criteria. In case of lateral lymph nodes, more than 7 mm are considered as suspicious. So recording the location and size of the lateral lymph nodes is important.
Simi, please move on to the last two, na CRM and
Yes, ma'am.
time is up. Just discuss about CRM and extravascular invasion.
Yes, ma'am. Then C, it stands for the circumferential resection margin. It is the margin that surgeon creates when performing the total mesorectal excision. It is the surface of non-peritonealized part of rectum, that is the low rectum. Upper rectum is fully peritonealized. Mid rectum is having peritoneal reflection only in the anterior part, and in low rectum, the rectum is non-peritonealized. So if CRM is less than 1 mm, that is a potentially positive margin is defined as tumor lying within 1 mm of the mesorectal fascia. 1 to 2 mm is considered as threatened, and more than 2 mm is considered as CRM negative. So CRM, it applies to suspicious lymph node also, as we can see. Then it also applies to the main tumor if it is within the 1 mm of the mesorectal fascia. Then it applies to extramural vascular invasion also, and to the tumor deposit. So here we can see.
Move on to next slide. Simi, your time is up.
Yes, ma'am. Then E stands for extramural vascular invasion. It is an independent risk factor for local and distant recurrence and poorer overall survival. If extramural vascular invasion is there, then there is high chance of recurrence. So it is defined as the presence of malignant cells within the blood vessels located beyond the muscularis propria in the mesorectal fat. So here we can see this vessel. It is having the same signal intensity as that of the tumor, and it is thickened and nodular in appearance. So it is involving the vascular vessels. So here we can see these are the normal vessels which are close to the tumor but are normal in caliber with no tumor signal intensity. In this case, we can see the vessel is expanded and having the abnormal signal intensity as that of the tumor. In this case, there is no abnormal intensity within the vessel. There is abnormal signal intensity within the vessels, but vessel size is nearly normal. Then in this case, we can see irregular vessel contour with nodular expansion of the tumor. So this is the example of extramuscular vascular invasion, extramural vascular invasion. So these are the main indications of giving preoperative chemoradiotherapy to the patient. If the tumor is locally advanced, like T3.
Dr. Simi, I'll request you to come to your last slide because these things will be covered by the other panelists and other speakers.
Okay, sir. So here is an example. This is the image of pre-CRT. Then after giving the CRT, we can see there is a fibrosis. We can see there is almost complete vanishing of the tumor, and in diffusion weighted, there is no diffusion restriction. So it is a complete responder to the neoadjuvant chemoradiotherapy. In this case, we can see that some tumor amount is there and it is restricting on diffusion. So that is a case of tumor remnant even after giving the neoadjuvant therapy.
Okay, so we'll go on to our mentor, Dr. Parul Garg. Thank you, Dr. Simi, an excellent presentation. We get an overview of the imaging. So Dr. Parul and Dr. Shikha, your comments.
So MRI definitely has a very important role in deciding whether only surgical excision has to be done, and especially the T3 stage has to be decided upon the mesorectal fat involvement, whether CRT is to be given as a pre-surgical option or not, to prevent local recurrence, as well as to give the best treatment option of sphincter preservation in the lower rectal cancers. Dr. Shikha.
Yeah. One small thing, because of lack of time, she couldn't cover. The restaging of tumors after CCRT has been given. One needs to remember that if you see mucin in that, then that could just be the liquefied area and may not be the tumor. So mucin seen upfront is different, mucin seen later on is different. So that is the only thing I think that I want to comment on. And yeah, and one more thing that the clinicians need to know that we no longer need to do an endorectal MRI. The MRI done now at a 3 Tesla is fantastic with the normal coil, and nothing needs to be inserted, and it's fantastic.
So any more comments from our mentors? So I have a question for Dr. Simi. Suppose the patient comes to you with a PET CT and you have a lower third or middle third rectal cancer. Would you ask for an MRI pelvis, and why? What additional benefit you get? This is something like your question for your final exam.
Yes. So, sensitivity of the PET CT or CT is less than MRI in case of local staging of low rectal tumors. So the CRM positivity, it is mainly we can see better on MRI, and the anal sphincter involvement. All these factors, they are best seen on the MRI. PET CT is usually for the metastatic workup of the patient.
Excellent. Thank you, Dr.
One more question can I ask?
Yeah.
How
Sure.
do you think MRI is superior to endoscopic ultrasound? Because gastroenterologists also can give you almost the similar finding. So how do you think that MRI is superior?
So,
So
Simi, you want to
endorectal
answer that?
ultrasound.
Yes.
Yes,
Endorectal ultrasound, it is good for T staging of the tumor, but for looking for the lymph node status, extramural vascular invasions, and all these things adjacent, we consider that MRI is superior than endorectal ultrasound.
So is it good?
Endorectal ultrasound is mainly good for T staging.
And also the endoscopic ultrasound is operator dependent. So you and the MRI can be studied by any number of radiologists or surgeon like that.
Yes.
Yes.
Yeah, Dr. Shikha?
Yes, she is absolutely correct. See, only the local T staging where T1 and T1A and B tumors, and that too the sphincter involvement, that for that endorectal endoanal ultrasound is good. But MRI has a larger field of view. Your end staging, the nodes, the local structures involved, that may not be covered by the field of view of an ultrasound.
So there's a question from Dr. Nikhil Agarwal. Are we still using endorectal MRI for?
No, it's been answered. It's been answered. We can leave it.
Yeah, okay. So thank you, Dr. Simi, Dr. Parul, Dr. Shikha. Wonderful presentation and discussion on imaging. So we'll request Dr. Simi to stay back for the panel discussion. So next we move on to the surgical topic. The presentation is by Dr. Mohan Reddy, who is the DNB Surgical Oncology candidate at Fortis Shalmabad. And I also invite the mentors for the session, Dr. Kapil Kumar and Dr. Nikhil Agarwal. So Dr. Mohan.
Yes, sir.
So you have a time limit 15 to 16 minutes.
Yes, sir. Good evening. My topic is sphincter preserving surgeries in lower third rectal cancers. According to NCCN, rectum is defined as that portion.
Can't see your screen. Share your screen.
I started sharing, sir. I already shared it, sir.
It's not coming.
I guess whosoever has been sharing it previously has to stop, then only he'll be able to share it.
Yes,
Okay, sir.
Now it's
Yes,
come. Yeah.
Yes.
yes, sir. My topic is sphincter saving surgery for lower third rectal cancers. According to NCCN, rectum is defined as that portion of bowel located below the pelvic inlet. It is an imaginary line drawn from the sacral prominence to upper part of pubic symphysis. And rectum is of variable length up to 12 to 15 centimeters. Lower third is of 0 to 7 centimeters from the anal verge, and it contains three mucosal folds, two on the left side, one on the right side, which are called walls of Houston. We are concerned with the middle rectal valve. The surgical importance of this valve is that it corresponds to the point of peritoneal reflection onto the bladder. Any tumor located below this is the lower third rectal tumor, and also this is the point where the lower third rectum is completely surrounded by mesorectal fat and fascia. And this middle rectal valve is approximately at a distance of 5 centimeters from the anorectal junction. Uh, Lower third rectal tumors are those which are at a distance of up to 8 centimeters from the anal verge, according to Japanese, and up to 7 centimeters in Western classification. Workup begins with rectal examination, serum CA levels, full-length colonoscopy, biopsy plus MSI, which should be done for young patients with family history or synchronous lesions, MRI with liver screening, PET-CT only in cases of high levels of CA, and when incomplete colonoscopy is and suspicious MRI findings. And rectal cancer surgery itself is technically challenging because of difficult access, difficulty in obtaining distal margin, circumferential margin, and to obtain good quality TME, sphincter preservation, and maintaining good quality nerve function. Aim of the treatment is to do a complete R0 resection, sphincter preservation, and improving disease overall survival, disease-free survival, and also improve the quality of life. Plan is always a multimodality treatment, usually upfront surgery followed by, for T1, T2 tumors, followed by adjuvant treatment based on final histopath reports. For T3, T4 lesions or node positive, or when sphincter is involved, when CRM is threatened or involved, these patients should be sent for neoadjuvant chemoradiation followed by surgery, or wait and watch policy based on local excision and follow-up. These are the options. IV chemotherapy should be given for the patients with lateral node involvement, bulky nodal disease at the root of IMA, or poor response to radiotherapy. Surgical options are for upper third, it is anterior resection. For middle third, it is low anterior resection. It is the anastomosis below the peritoneal reflection, but above the anorectal ring. Lower third, it depends on the modified Roulier and modified Roulier classification, which goes like this. Type 1 tumors are the supraanal tumors, where the lower edge of the tumor is more than 1 centimeter from the anorectal junction, where we can obtain 1 centimeter of distal margin and perform coloanal anastomosis. Type 2 are juxtaanal tumors, where lower edge of tumor is less than 1 centimeter from the anorectal junction. To obtain 1 centimeter distal margin, we have to go through the sphincters. So we can perform partial intersphincter resection in this category. Type 3 tumors are those intraanal tumors where the tumor has entered into the anal canal without involving intersphinctic space. For them, total intersphinctic resection can be performed. For type 4, a transanal tumor, when the tumor extends into the space and involves the external sphincter, we have to remove the entire sphincters and part of levator depending on the tumor. Planning sphincters preservation in a patient. It is a complex procedure, begins with good colonoscopy and biopsy, MRI for local staging, and CT for ruling out metastatic disease, and giving patient neoadjuvant treatment based on the high-risk features, and assessing the patient after neoadjuvant chemoradiation for the feasibility of sphincter preservation, planning surgeries 6 to 10 weeks after treatment, also to assess the sphincter function preoperatively for the good quality of sphincter tone, taking history about obstetric and surgical trauma. Patients should be counseled about the option of APR and also told about suboptimal bowel function even though sphincter is preserved. And 10% of the patients might still require permanent stoma after sphincter preservation, and about the possibility of local recurrence, which is up to 6% or slightly higher than APR. Sphincter saving procedures available are low anterior resection, ultra low anterior resection, intersphinctic resections, transanal local excision, and transanal TME. For all rectal cancers, especially lower third, total mesorectal excision is the basis for the surgery, which can be done by means of open, still considered as a standard of care, laparoscopic, hybrid, robotic, and transanal TME. TME was first described by Bill Hill in 1982. The main components of this procedure is in the correct plane between presacral fascia and fascia propria of rectum, sharp dissection under good illumination between hypogastric nerves and superior rectal artery, the holy plane. Complete TME to obtain unbreached fascia in the specimen, high ligation of the vessels with good distal margin of 1 centimeter and circumferential margin of 1 mm. And stable line should be horizontal at the same level of bowel and mesentery. IMA is the gateway to the pelvis. It should be ligated 1.5 centimeters after its origin from the aorta. Avoid skeletonization of the aorta because underneath it lies the superior hypogastric plexus, and avoid mass clamping of the vessels near the root. Once this is done, posterior rectal dissection begins. It lies in the between presacral fascia and fascia propria of rectum in the holy plane. When you reach at the level of S3, S4, sharp dissection should be done to divide the Valder's fascia. Avoid blunt dissection as it can cause torrential hemorrhage from the presacral plexus. Once this Valder's fascia is dissected, it will lead you to the levator and pelvic floor muscles. This is followed by the lateral dissection, where it should be started only once the posterior dissection is done. At the pull it medially, otherwise it can pull the inferior hypogastric plexus medially and can damage. And it is advised to go close to the mesorectal fascia while doing lateral dissection in the lateral stacks. Also, at the same time, avoid going too medially, anteriorly. It can take you to the mesorectal fat, fascia, and posterior margins. At the same time, avoid going too anteriorly, which can damage the nervi regenerative and cause erection problems. Once this is done, anterior dissection should be started. For tumors located in the posterior and lateral wall, posterior dissection should be posterior to the denon-Wheeler's fascia. For tumors located anteriorly, it should be anterior to the denon-Wheeler fascia. Caution is mentioned at the level of 2 o'clock and 10 o'clock position, where neurovascular bundles are present. Damage should be avoided to them. Once we dissect the denon-Wheeler's fascia, the denon-Wheeler's fascia will fuse with the prostatic capsule at its base. Once we reach this, posterior dissection will take you into the bare area of the rectal tube, where there is only mesorectal fascia and no mesorectal fat. After this, specimen resection with using contour stapler, followed by colon-analysis, taking a circular stapler. For this, anvil is introduced into the cut end of the colon, followed by taking a tight pursing sutures. Later, circular stapler is introduced through the rectum. The both are approximated when locked and fired. At the end, the specimen should be examined for the complete anastomosis, and donut should be sent for histopathological examination. Since distal donut itself constitutes about 3 to 5 mm in length, which could be a good distal resection margin. And superior hypogastric plexus, which contains sympathetic nerves. Potential site of injury is that the ligation of IMA, which can cause damage, causes urinary incontinence and retrograde ejaculation. Inferior hypogastric nerves, nerve urgentis, both contain sympathetic and parasympathetic fibers. This can damage at the lateral stalk division. Damage can cause atomic bladder and impotence. Once the specimen is out, it should be examined for the shininess of the TME, look for the defects in the TME, and look for the shiny surface, look for the peritoneal reflection above the cul-de-sac, which should be at least 1 centimeter, look for denon-Wheeler fascia and bare muscular tube. Next is transanal TME. It is a hybrid approach, combination of transanal and transabdominal transanal approach. Transabdominal is similar to regular procedure, whereas transanal approach can be done either by means of minimal invasive surgery with flexible instruments or transanal endoscopic surgery with rigid instruments. This is the platform for endoscopic surgery and minimal invasive surgery. For minimal invasive surgery, single incision laparoscopic port can be used with regular laparoscopic instruments. Transanal TME excision, why, when, and how, by a study by Marta Penna, in which a systemic review was done in 36 studies on TATME with a total of 510 patients. The results were comparable 12 centimeters from the anal verge, diameter of more than 4 centimeters, which require adequate distal resection margin. The 5 key operative steps for TATM is: first is taking adequate pursuing suture, followed by full thickness rectotomy, TME dissection, specimen extraction, and anastomosis. Steps begin with the placement of a star-lung self-retaining retractor, followed by taking a pursuing suture, which should be 1 centimeter below the lower edge of the tumor and should begin at 7 o'clock with small bites between 2 bites, small distance between 2 bites, and it should be complete airtight and avoid spiraling up of the suture. Spiraling up can cause closed margins or positive margins. Advantages of this pursuing suture is: one, it prevents the spillage of tumor cells into the dissection plane to avoid fecal contamination and maintain adequate rectal wall tension on CO2 inflation. Next is full thickness rectotomy. It should be tangential exactly at 90 degrees. Any obliquity can take you into the rectal wall, which can cause closer positive margins and sometimes perforation of the rectum. This followed by posterior dissection. It should begin the posteriorly in the holy plane. Care should be taken at the sacral curvature. It should be along the sacral curvature in the holy plane. Any obliquity are going too horizontally will take you into mesorectal fat and fascia, leading to positive margins. This is followed by anterior dissection and lateral dissection. This posterior, anterior, and lateral dissection will help you in protecting the inferior hypogastric plexus and avoid injury. Later, this is followed by specimen extraction through the anus, resection followed by Hansen or stapler anastomosis. There is upcoming Color 3 trial comparing laparoscopic versus transanal TME. Hopefully, it might provide conclusive evidence of the true risks and benefits of this novel technique. And there are also studies exploring alternative parameters that could guide patient selection for TATME, such as use of CT or MRI using pelvimetry measurements. And also in 2014, a transanal TME registry was started by 29 countries, registering 720 patients. Results are yet to be published. The results might tell us about patient selection, tumor character selection, and tricks about the surgery and benefits of the surgery over other procedures. Intersphincteric resection by Philip Roned for the patients in which they were initially indicated for APR. They found that after 10 years of this study, all the results are in favor of sphincter saving surgery in terms of local recurrence, overall survival, disease-free survival. And also they noted that there is no difference whether you perform partial surgery, partial intersphincteric resection or complete intersphincteric resection after 10 years. Another surgery by Norio Sato, in which 228 patients were included and tumors less than 5 centimeters from the anal verge, they found success rate of 86% with a morbidity of 24%, mortality 0.5%. And 5-year disease-free survival over survival is 92% and 83%. They also found that on histopathologically examining the specimen, they found acceptable oncological and functional outcomes of sphincter preservation. After this, who needs defunctioning angiostome? Patients who underwent ultra-low anterior resection, patients with sphincter preservation, patients post-neoadjuvant chemoradiation. Contraindications are sphincter preservation or T4 tumors post neoadjuvant treatment, still invasion of external anal sphincter, fixed tumors, poorly differentiated tumors, poor preoperative sphincter function, and distant meds. Coming to local excision, indications for local excision: clinically, the tumor should be less than 3 centimeters, less than 30% of the circumference, and clear margin of at least 3 mm should be available. Tumors at a distance of 8 centimeters from the anal verge, freely mobile, limited to upper third of the submucosa, no nodal involvement, no LVA, PNA, no mucinous or significant components. They said that at least 1 centimeter of gross circumferential margin is required while dissecting, and depth of 3 millimeters into the parietal fat should be taken. Once this obtained, it should be closed transversely. Though local recurrence rates are high, for T1 it is around 18%, for T2 it is 47%, but survival rates are higher. For T1 it is 72 to 90%, T2 it is 55 to 78%. Comparison of techniques for local excision, transanal excision, endoscopic microsurgery, minimal invasive surgery. The basic differences between these three is: one is the tumor distance up to which procedure can be undertaken. For TIE it is up to 8 centimeters. For TEM it is from up to 4 centimeters to 15 centimeters. This 4 centimeters is because of the rectoscope, which is itself is 4 centimeters. Minimal invasive surgery up to 15 centimeters. Another difference is the Patient position for the first two, it is tumor dependent. For minimal invasive surgery, it is lithotomy. Field of view for transcranial excision is about 180 degrees. For endoscopic microsurgery is 220 degrees, and time is minimal invasive surgery it is 360 degrees. Patients who can for whom local excision can be offered is elderly patients, trial and high anesthetic risk, patient who refuse to stoma and radical treatment. This is a prospective randomized multicentric phase 3 trial by Eric Ruller, in which local excision was compared to total mesorectal excision with a good response after chemoradiotherapy for lower rectal cancer. The primary endpoint was to see the recurrence rates to show superiority of local excision over total mesorectal excision. Inclusion criteria was T2, T3 tumors, size 4 centimeters, and good clinical response to neoadjuvant treatment, residual tumor size less than 2 centimeters. End results were like they failed to show the superiority of local excision over TME, but the findings suggest that oncological safety of local excision in terms of local recurrence, disease-free survival at the end of 3 years, there is no difference between the two groups. And they also noted that in the final histopathology of T0, T1, and most cases with T2, they suggested that complete total mesorectal excision was not necessary as the nodal response was too good. Few slides on LAR syndrome. It is a constellation of syndrome post rectal resection. It is variable, unpredictable bowel function, emptying difficulties, altered stool consistency, urgency, painful stools, increased frequency, incontinence, and soiling. Risk factors include female patient, younger age, neoadjuvant treatment, total mesorectal excision, lower tumor, and the duration of temporary diversion. More the duration, more is the risk factor. Surgical reconstruction techniques to reduce LAR syndrome to some extent are straight colonal anastomosis, colonic J-pouch anal anastomosis, end-to-side anastomosis, and transverse coloplastic pouch. Take-home message: T1 and 0 patients with good risk factors, that's low risk factors, should undergo local excision, and other T1 and T2 lesions should undergo radical surgery with TME. T3, T4 node positive should undergo neoadjuvant chemoradiation followed by surgery or wait and watch. For T2, T1 lesions, upfront surgery is a treatment of choice. NSCRT will lead to significant chemotoxicity. Intersphinctic resections results are as good as APR. To maintain good sexual and urinary voiding functions, and attempts to reduce LAR syndrome. Thank you.
Thank you, Dr. Mohan, for an excellent presentation. Over to Dr. Kapil sir and Dr. Nikhil.
I think Dr. Nikhil should make comments first because Mohan is working with me. I can take it on later.
Sure. Thank you, Kapil. And Mohan, I must congratulate you for an excellent presentation. You have covered the whole topic very well. And there are a couple of final points which I would want to make. One, when we talk about upper, mid, and lower rectum, so distance in centimeters is not a very, very good idea because most of these distances we have taken from Western population, and like classical definition of rectum is say 12 to 15 centimeter. For our patients, they are very short, their rectum is much shorter, and especially older age, the rectum descends. So we'll have to look at the MRI, and there we have to take whether it's upper, mid, and lower rectal cancer, right? So broadly, like, though, I mean, there will be some variation whenever we talk about, but like 2 centimeters from anorectal ring is the lower rectal cancer. So it's very low part of rectum, which is low. Anything below peritoneal reflection is mid, and there is an angulation after upper rectum. So on MRI, there are 2-3 ways you can see it sideways, where the rectum will fall like this, and if you see it on axial, then rectum will bend like this. So that is a marker of upper rectum and sigmoid. So these are the criteria we should use when we talk about upper, middle, and lower rectal cancer. Second, when we talk about multimodal treatment of breast, mostly multimodal treatment was T2 tumors where because of their proximity to sphincter, we might end up giving them some neoadjuvant treatment. But broadly in upper and mid rectal cancer, and specifically upper rectal cancer, if CRM is free, we can operate node positive patients also without giving neoadjuvant treatment, right? So that is one thing. Second, when we talk about this nomenclature, like say LAR, not LAR exactly, LAR is standard, but ultra low is not very standard. Again, ISR definition is also not very standard. So that we have to always keep in mind, because different people will use different terms for these ultra low and ISR and all those things. They are not standardized. When you talked about IMA dissection, you said 1.5 centimeter. Generally, broadly, I mean, we wouldn't agree with that. It will also depend on. It will also depend how far down we want to go. Whether we want to preserve the left branch of IMA, left colic branch of IMA. So these are the considerations which you will have to take before you decide where to want to do. So 1.5 centimeter is not the cutoff. Sometimes we'll take it at base also if there are large nodes there to give adequate nodal clearance. And when we talk about sphincter saving resection like ISR and all that, so obviously there are multiple factors which we need to consider, and obviously MRI is the workhorse, or based on which we decide where we'll be able to do oncological adequate resection. And two, we also have to always consider about the functional outcome of ISR, right? So if we don't choose our patients well for doing ISR, their quality of life probably might not be that good. They might have incontinence, and it requires very judicious judgment on the part of the surgeon to offer ISR to only well-selected patient. I guess these are the comments which I want. And
thank you, Dr. Nikhil. I would make one or two quick points. One is the presentation of obese patients to us, and with that, the advent of laparoscopy and robotic surgeries has come up in a big way, and that can be helped by by doing this minimally invasive surgery. Another point I would like to make is about the poorly differentiated tumors, where after neoadjuvant therapy, how much margin to go take after the neoadjuvant therapy, that is to be considered, or a patient may be converted to abdominoperineal resection extra levator once the there is an obese patient and a poorly differentiated tumor.
So thank you.
Dr. Nikhil made very good summary of the whole presentation, and Mohan, you made a very good presentation.
Thank you.
I think Dr. Mohan, you made a very important comment in the counseling part, that consent for permanent stoma for any patient. So that's very important, and you would realize if you burn your finger once. So thank you, Dr. Mohan. Thank you, Dr. Mohan, Dr. Kapil sir, Dr. Nikhil. So we move on to our second part, chemoradiation and chemotherapy, and I invite Dr. Abhishek Gulia to take over.
Right.
Thank you, sir. Rather, for the next session, for the previous sessions, I'd like to thank the radiologists and the oncosurgeons. Now, one of oncologists to take over. I request Dr. Sarupa Mitra and Dr. Charu Garg, both very senior radiation oncologists in Delhi, to kindly take over for the session and invite the presenter for short versus long pre-op radiation, rectal cancer.
Am I audible?
All right, I think begin the talk, and I request you kindly stick to time. We are already behind schedule. Thanks.
Okay. So first of all, I would like to thank the organizers for this opportunity. So I'll present on the topic of preoperative radiation for rectal cancer, long course versus short course radiation. So very briefly regarding the evolution of treatment that we have observed in carcinoma of the rectum. So in the 1980s, surgery was considered to be the main modality for the treatment of carcinoma rectum. And then it was in the year 1986 onwards that with the advent of TME, better outcomes were achieved in terms of reduced local failures. And eventually, it was seen that the addition of any form of neoadjuvant treatment, for example, in the form of neoadjuvant radiation, there was improved local outcomes. So it was then in the year 1997 that short course radiation was for the first time introduced along with TME. And then eventually in the year 2004, there was further studies regarding comparison of preoperative and postoperative radiation therapy along with surgery. In the year 2005, it was seen that adjuvant chemotherapy does not improve the outcomes after the administration of chemoradiation. So this is how the treatment of rectal cancer evolved over the years, with the important trials comparing the short course as well as the long course radiation in this particular cancer, with the Polish trial as well as the other trials such as the Stockholm trial and the TROG trial. And then eventually it was in the year of 2018 that the wait and watch strategy was established. And then presently the total neoadjuvant therapy as a standard of care is being established by various trials such as the Rapido, Prodige, etc. So moving to our main topic, the first and foremost is the presence of the preoperative short course radiation trials in the pre-TME era. The main trials being the Stockholm 1, Stockholm 2, and the Swedish rectal trials, which were brought out in the year 95, 96, and 97 respectively. So the most important out of these was the Swedish rectal cancer trial, which was a phase 3 randomized controlled trial of over 1,100 patients, which compared the preoperative short course RT followed by surgery versus surgery alone. So it was seen that there was statistically significant difference in terms of the local control as well as the overall survival at the end of 5 years as well as at the end of 13 years. This results, they were maintained. So it was then concluded as a result of all these 3 trials that the local control was much better with the addition of preoperative chemotherapy. That is, the local relapse rates, they reduced to almost half of it. And an important factor here was that the Swedish rectal trial, it also demonstrated a survival benefit, which was found to be significant, but it was later attributed to the probable poor surgical techniques at the time these trials were conducted. So later on, to remove this bias, there were various other studies that were conducted in the post-TME era. The important ones being the Dutch TME trial and the MRC CR07 trial. The Dutch TME trial compared the preoperative short course radiation followed by total mesorectal excision versus the TME alone. And after a median follow-up of 10 years, it was seen that the overall survival was not significantly different. However, there was a difference of 5 versus 11% in local relapse rates. It was then concluded that both these trials confirmed reduction in the local relapse. However, the overall survival was not improved. So very briefly about the German rectal cancer trial, which was published in the year 2004 in the NAJM journal. And it is aimed to compare the preoperative versus the post-operative RT and concluded that preoperative chemo RT improved local control and was also associated with reduced toxicities. However, it did not show any overall survival benefit, but the sphincter preservation rates, they were considerably increased, and this trial established the role of preoperative treatment in the rectal cancer modalities. So the basic rationale for the addition of neoadjuvant radiation is to downstage the tumor and also facilitate sphincter preservation. It offers potential advantages such as possible sphincter preservation, reduction in tumor size, treatment of smaller fields with lesser irradiation, and also prevention of small bowel and other organ toxicities. It helps in irradiation of well-oxygenated tissues and also provides a theoretically greater benefit. It helps to avoid radiation to the neorectum. However, it also comes at potential disadvantages in the form of a possibility of treating early stage or metastatic disease who would potentially not benefit from such a treatment. And it also results in delay of surgery, which is an important treatment modality. So a general comparison of the short course and the long course radiation. In a short course radiation protocol, we are delivering a dose of 25 gray in 5 fractions, which is given at a dose rate of 5 gray per fraction. The treatment completes in a duration of 1 week. It has got a good BED, which is a biological equivalent dose, and the time to surgery, if we are not following it up with the chemotherapy, is usually about 7 days. It does not result in tumor downstaging if it is not delayed, if the surgery is not delayed. So no concurrent chemoradiation is given along with chemotherapy is given along with it. The acute toxicity is cured if the patient is subjected to immediate surgery, and the rate of late toxicity is only less than 10%. When it comes to the long course radiation therapy, a total dose of 45 to 50.4 gray at a dose rate of 1.8 to 2 gray per fraction is given over a duration of 5 to 5.5 weeks. The time to surgery after completion of this radiation is usually 6 to 12 weeks, and it results in tumor downstaging of approximately 50%. It is also administered along with concurrent radiosensitizing chemotherapy. The acute toxicities are to a tune of 10 to 24%, which are usually grade 2 to 3, and the late toxicities are again less than 10%. So there were a few major randomized control trials which directly compare the short course and the long course radiation therapy. The first one being the Polish trial, which was published in the year 2006. It comprised of 312 patients, which were subjected to 2 arms, first being preoperative short course radiation, followed by immediate surgery within a duration of 7 days, and second arm being chemoradiation, followed by surgery after 4 to 6 weeks. So this particular trial showed that early radiation toxicity was much higher in the chemo-RT arm, which was statistically significant, 18 versus 3%. However, the 4-year overall survival rates, the DFS, the local relapse rates, and the late severe toxicities, they were not found to be different. Hence, it was concluded from the Polish trial that the neoadjuvant chemoradiation did not increase survival, local control, or late toxicities when compared to short course radiotherapy alone. Next important trial in this regard was the Trans-Tasman Radiation Oncology Group trial, 01.04. So in this trial comprising of 326 patients of locally advanced CA rectum, the categorization was made into 2 arms, the short course radiation therapy followed by early surgery, and the other arm comprised of long course radiation therapy followed by surgery after 4 to 6 weeks. The chemotherapy in the adjuvant setting was optional, and this trial was published in the year 2012. This trial helped us conclude that at the end of 3 years, the local relapse rates, they were not statistically different. And also at the end of 5 years, the distant recurrence rates were comparable. The 5-year overall survival was also comparable in both the arms, and the late toxicity rates were also similar. So it was seen that there wasn't any major difference in the 2 arms, and both the arms were found to be comparable. So a concluding slide for the true trials. It helped us come to the inference that tumor downstaging, pathological complete response rates, and loco-regional relapse rates, they are better with the chemo-RT arm. However, there is no conclusive evidence which favors any survival benefit or any sphincter sparing benefit in both the modalities. Next came the Polish 2 study, which was published in the year 2019. Over here, 515 patients of T3, T4 rectal cancer were divided into 2 arms. First one being the chemo-RT arm, which was the standard fractionation along with radiosensitizing chemotherapy, followed by surgery, and the other arm comprising short course radiation therapy, followed by 3 cycles of FOLFOX, followed by surgery. So this was one of a kind trial where for the first time after short course radiation, chemotherapy was administered. So the primary endpoint of this trial was the rate of radical surgery, and it was seen that there was no difference in the rate of radical resection or any overall survival, local control, DFS, or late toxicity difference. But it was definitely seen that in terms of tumor downstaging, the long course radiation fared better. This trial did not demonstrate any superiority of preoperative short course or long course chemoradiation. The next important trial in this regard was the Stockholm 3 trial, which was a multi-center randomized phase 3 non-inferiority trial of 840 patients. This trial divided the patients into 3 arms. So the short course radiation therapy with a delay to surgery was found to be a useful alternative to the conventional short course radiation therapy with immediate surgery. So next we'll move on to the advantages of both these techniques. When it comes to the long course radiation therapy, it is seen that chemotherapy, which is administered along with radiation upfront, helps to prevent micrometastasis. It also helps to prevent the repopulation during the course of radiation. The tumors are given this modality when they have an intact blood supply, so they have a theoretical benefit. There's potential for organ sparing if the tumor downstaging is done. Similarly, they also have a potential for curative resection and sphincter preservation. The surgical morbidity is presumed to be lesser, and also there is a decreased incidence of positive resection margins. Whereas when it comes to short course radiation therapy, the greatest advantage is the greater compliance of more than 90%. It also avoids accelerated repopulation in the tumor. It also, again, irradiates the tumor, which has an intact blood supply. The rates of acute toxicity are lower. It is more logistically better for the patient as well as for the treating physicians. And the trials, they have shown improved local control with the use of SCRT. The advantages of disadvantages of long course radiation therapy is obviously a greater treatment time. Then also because of decreased compliance, it helps to delay the utilization of full systemic adjuvant chemotherapy, which is necessary for the overall treatment of the patient. It also worsens the compliance and is expensive for the patient. Whereas the short course radiation therapy has the disadvantage of providing no downstaging. If it is followed by immediate surgery, it has no potential for organ sparing and does not increase any chance of curative resection. And also it only partially compensates for a positive CRM. A next pertinent question is regarding what patients to be selected for which kind of radiation therapy. So as a general rule, all the patients usually that can be a candidate for a short course radiation can also be a candidate for the long course radiation therapy. But the candidates who are better off for a long course radiation therapy are the ones in which we want a greater or better downstaging of the tumor. So patients with very bulky diseases, for example, a T4B disease, or in which there is a threatened or positive CRM, are better candidates for the long course radiation therapy. Moving next to the interval between between the surgery and the preoperative treatment modality. So this question was answered by various studies, one of them being the Stockholm 3 trial, where a subset analysis of the Stockholm 3 trial helped us to assess the tumor regression as well as the correlation to the survival. So it was seen that the pathological complete response is maximum after the short course RT with a delay, as well as the TRG4 is maximum after the short course radiation with delay. So this was analyzed with a Dvorak grade 4 assessment, and hence adequate interval between the preoperative treatment and surgery is important. So various other studies have been done in this regard to study the appropriate time. And one of the studies suggests that at least 12 weeks interval between the start of the treatment and the performance of the surgery is important. The various guidelines which have given this interval are the ESMO and NCCN. So ESMO advocates a time interval of 6 to 8 weeks between the pre-op treatment and surgery, whereas NCCN recommends a time interval of 5 to 12 weeks. For the short course radiation followed by immediate surgery, the appropriate time interval is 7 to 10 days, and a time interval of 6 to 8 weeks between short course radiation and delayed surgery is considered as appropriate. So this time interval helps in tumor regression, which is an important prognostic score, and also aids better pathological complete response, which is important for local control as well as translates into overall survival. However, we do have a few meta-analysis that suggest that treatment delay between beyond 11 weeks is could be hazardous. So another important trial, which is the Rapido trial, is a randomized open label phase 3 trial, which compared the short course radiotherapy followed by chemotherapy before TME versus preoperative chemoradiotherapy followed by TME, and also optional adjuvant chemotherapy. So it was observed in this particular trial that there was a decreased probability of disease-related treatment failure in the experimental group, in probably indicative of increased efficacy of pre-op chemotherapy as opposed to adjuvant chemotherapy in this setting. So the experimental arm of short course chemotherapy followed by short course radiation therapy followed by chemotherapy could be a new standard of care.
Dr. Shefali, can you wind up?
Yeah, just one slide. So a few upcoming studies are also looking at further dose escalation beyond 25 grain 5 fractions. The various contouring guidelines are by Vincenzo Valentini and the National Rectal Cancer Guidelines. So here I would like to suggest that ESMO has given a clear demarcation of which patients we should be preferring for the short course radiation therapy and which ones for the long course chemoradiation. So if a patient has a clear MRF, levators are not threatened, the tumor location is in the mid or the lower rectum with T3, N1, N2 disease and EMBI positive. In such scenarios, short course radiation can be preferred. And in the patients where there is MRF involvement, levators are threatened, the location is mid to lower rectum, T4B, and lateral node positivity. These are the cases where we would prefer the long course chemoradiation. Again, moving to the NCCN 2022 guidelines, which has clearly suggested that both long course chemoradiation as well as the short course chemoradiation, they are similar in terms of outcomes. So the patient selection for either of the two modalities is multifactorial. However, this just comes with a small remark that with the use of short course radiation therapy, a multidisciplinary team meeting is always advised. Thank you.
Thank you, Dr. Shefali. There's a question from somebody, like, are these different target volumes which we contour for short course and long course? Do we have to do it differently?
So the basic difference in the two is that when we are doing it for the short course radiation therapy, that target volume delineation is comparable to the phase 1 of the long course chemoradiation. However, when we are giving a sequential boost in case of the long course chemoradiation, that is when we are coning it down to the gross tumor disease along with the gross nodal disease with a direct margin to compensate for the setup and the internal margins. So up to a dose of 45 gray, which we are giving in the long course, we are treating the entire elective nodal station along with the gross disease and the mesorectal fascia. So the difference in terms of the short course and long course only comes in the phase 2, the sequential phase.
All right. Thank you for the wonderful presentation. I request the mentors to please take over.
So Dr. Charu, please first, because Shefali is my PG.
So first of all, it was a great presentation by Dr. Shefali, and she's very beautifully taken us from 1990s to present. And if I can recall, like around 2 decades back, it was always surgery upfront where we as radiation oncologists would be treating post-operative radiations with APR, putting markers for the APR resections and all that stuff. So this has taken approximately a 180-degree turn in the management of CA rectum. Now coming on to the short course versus the long course, I think Dr. Shipali is beautifully, tabulated which are the patients where a short course radiation can be done. And as we are sort of, moving ahead with the trials, now even ASMO says even with patients who have got CRM threatened or who are T3 or T4, even those patients can be considered for short course. The only caveat here is I think it has to be a multidisciplinary approach, and the surgeons, the radiation oncologists, and the medical oncologists have to sit together to decide about the plan of the treatment. What do the surgeons expect from the radiation? Do they want downsizing? Do they want sphincter preservation? So all these indications sort of go towards giving a long course to the patient. And now we know with the advent of TNT coming in, like, total neoadjuvant treatment where short course is followed by full chemotherapy, followed by surgery, where again, a short course plays an important role. So that would be from my side. And I think IMRT has really played a lot of, game. It has really, cut down on the side effects. And recently, I think in 2021, there was a meta-analysis where it had 8 studies, and it showed that the short course and the long course RT had a similar profile of toxicities and the outcomes as well. So that's it. Over to you, Dr. Swarupa.
Yeah, thank you, Dr. Charu and Shefali. It was very nice, and I have seen you have worked very hard to present this. So yes, Dr. Charu has said everything. So I think we started the journey of rectum cancer started with short course, and we have again fallen back to short course. So it was just a small period of CTRT, long course CTRT. So answering the question which is there in the question answer section, yes, if the lymph nodes are positive, yes, we can go ahead with short course radiation. So there is no direction that such patients should not be taken for short course radiation. The only right now we would be again talking to the surgeon if there is a very low lying tumor, a T4B tumor, and a threatened or a positive CRM, then whether we go for long course radiation or short course radiation. So that is those areas are only the gray areas where, no, I won't say gray areas, it would be personal choice, customization, whether we go for short course radiation or long course radiation. The advantage here we have is now that it is no more short course radiation followed by immediate surgery. It is a delayed surgery with the chemotherapy filling that gap. So whatever disadvantage the short course radiation had, this delayed surgery has overcome that. So soon we will be completely going to that era when it will be only short course radiation with delayed surgery, unless and until the total neoadjuvant treatment takes us over. So thank you, everyone. And Shefali, it was very nice.
Thank you.
Thank you, Mans, and thank you, Dr. Shefali, for the wonderful presentation. And now is the turn for medical oncologists to take over. I request Dr. Denny Gupta and Dr. Atul Sharma to mentor the presenter, Dr. Sachit Anand from Dharamshila Cancer Hospital, who will be presenting on TNT for rectal cancer.
So good evening, everyone. So I invite Dr. Sachit. He is from our institute, Dharamshila Narayana Cancer Hospital, to present his talk on total neoadjuvant therapy in locally advanced rectal cancer. Dr. Sachit, please.
Yeah. So is it visible?
Yeah, you can make it in a full screen. Correct.
Yeah. So good evening, all. I'll be dealing with TNT, total neoadjuvant therapy in locally advanced rectal cancer. So historically, therapy for locally advanced rectal cancer included concurrent chemoradiation followed by surgery and adjuvant chemo. Presently, with the after a few of the relevant trials regarding TNT, total knee origin therapy has become a standard as per the new guidelines of HCCN, which involves TNT involves administration of chemoradiation plus neoadjuvant chemotherapy before surgery with the goal of delivering uninterrupted systemic therapy to irradiate micromets. So, definition of locally advanced rectal cancer. It's still a vague term, as in there is no international consensus on the definition. According to ASCO, the definition varies from tumor growth into the mesorectal fat, that is clinical T3, tumor presence 1 millimeter or less into the mesorectal fascia, clinical T4 stage, lymph node mets, N1 stage, lymph node metastasis lateral to the mesorectal fascia, extramesorectal N1 to extramural vascular invasion. So coming to the sequence of TNT, total neoadjuvant therapy can either be starting with induction chemotherapy followed by chemoradiation and surgery, or consolidation chemotherapy, where CTRT is followed by systemic chemo and surgery, or short course RT followed by systemic chemo and surgery. Coming to the 2023 NCCN guidelines regarding TNT, so proficient MMR T3 NEN, T1, T2, N1, N2, and T4 NEN. Here we can either go for induction chemotherapy, long course we can also go for induction chemo of 12 to 16 weeks for folks or capox, followed by long course chemoradiation or short course RT, followed by restaging and surgery or surveillance. So this is the same thing, treatment schedule that one shows: long course chemoradiation followed by consultation chemo for 16 weeks, followed by restaging and followed by surgery. Treatment schedule two is showing induction chemo followed by long course chemotherapy, long course chemoradiation followed by restaging and surgery. So coming to the common dosing schedules, most commonly used in concurrent chemoradiation is external beam RT plus capecitabine 825 milligram per meter square twice daily, 5 days a week, or EBRT with 5FU leucovorin. It can be 5FU IV bolus and for 4 days for week 1 and week 5 of EBRT, or it can be continuous infusional 5FU at a lower dose of 225 milligram per meter square, but daily on days 1 to 5 for 5 weeks with RT. For neoadjuvant chemotherapy, the most commonly used regimen is modified FOLFOX6 and also capox. So coming to advantages of total neoadjuvant therapy, there is enhanced compliance with planned therapy. That is, the patient is more likely to complete the entire course of chemotherapy if given prior to surgery than in case of a post-op chemotherapy. There is reduction in tumor stage, that is downstaging of tumor, and there is increased likelihood of sphincter preservation and arterial road resection. There is exposure to chemotherapy earlier that targets occult micromets, and it can also help assess the tumor chemosensitivity. So coming to certain trials that are relevant to TNT, the earliest and most important will be Rapido trial, which initially set the tone first for TNT, as in it changed the scenario from always going for post-op chemo to coming to a situation where pre-op chemo was acceptable. That is Rapido trial. The other trials are Prodigy 23 trial, AO 12 trial, and Opera trial. We'll discuss it further. So Rapido trial, here short course RT followed by chemotherapy before total mesorectal excision versus pre-op CTRT, TMO, and optional adjuvant chemotherapy in locally advanced rectal cancer. So here the experimental arm was arm A, where short course RT followed by chemo followed by TME was used, and the standard arm used CTRT followed by TME and chemotherapy. So coming to the results, the most important difference between the two arms was the disease-related treatment failure, which was significantly lesser in the SCRT arm, SCRT and TNT arm compared to the historical standard. And coming to distant metastasis also, there was a considerable improvement in the TNT SCRT arm. And coming to pathological complete response, it actually doubled compared to the standard arm. So Rapido trial essentially reversed the TNT order, where the short course RT followed by neoadjuvant chemotherapy was given prior to surgery. And here there was doubling of the PCR rate, and there was a 7% higher distant metastasis-free survival at 3 years. And the toxicity was comparable, and as well as surgical complications. The 3-year OS was also similar. So for interpreting, there is decreased disease-related treatment failure in the experimental group, that is a SCRT TNT group, probably indicative of the increased efficacy of preoperative chemo as opposed to adjuvant chemo in this setting. Therefore, the experimental treatment can be considered as a new standard of care in high-risk locally advanced rectal cancer. Now coming to the second trial, the Prodigy 23 trial, where NICT with FOLFIRINOX and preoperative CTRT for patients with locally advanced rectal cancer was used. This is different from the other TNT trials in that we use FOLFIRINOX in the neoadjuvant setting in place of FOLFOX. So here the arm A was chemotherapy followed by chemoradiation and TME followed by a short course of chemotherapy, and arm B was a standard arm, that is chemoradiation followed by TME and chemotherapy. So here also the main difference was disease-free survival, which is significantly better in the experimental arm, and distant metastasis was also lesser, and PCR actually more than doubled in the experimental arm, where we used a neoadjuvant CTRT. So in this trial, Conroy et al. Compared a triple drug regimen followed by chemoradiation with 3 months of adjuvant modified FOLFOX or capecitabine versus the standard of chemoradiation with 6 months of adjuvant chemo. The PCR rate was significantly higher in the induction chemotherapy arm, and DFS was also improved. They have also reported a trend towards improved quality of life in the TNT group with lower rates of impotence. Now coming to the third trial, that is the AAO12 trial. Here, both the arms were total neoadjuvant therapy, and this trial mainly dealt with what sequence of total neoadjuvant therapy we should be preferring. So the arm A was chemotherapy followed by chemoradiation and TME, that is induction chemo arm. And the arm B was CTRT followed by chemo and TME, that is a consolidation chemo arm. So in this trial, the main difference was only in pathological complete response, where there was a significant improvement in PCR in the consolidation arm as compared to the induction chemo arm. The rest of the outcomes, that is DFS, pelvic recurrence, distant mets, and OS were comparable. So that is it. PCR was actually 17% in the induction arm and 25% in the consolidation chemo arm. DFS, OS, pelvic recurrence, and distant mets were comparable in both arms. So coming to the last trial dealing with TNT, the OPERA trial. The OPERA trial was actually designed with the purpose of post TNT, whether we should go for surgery or a wait and watch approach. So chemotherapy followed by chemoradiation and total mesorectal excision or wait and watch was compared with chemoradiation followed by chemotherapy and total mesorectal excision or wait and watch. So here also the comparison of TNT was between induction chemo TNT and consolidation chemo TNT. Here the main difference was in organ preservation rates. Organ preservation rates was again much higher in the consolidation chemo arm compared to the induction chemo arm. So the other key takeaways of OPERA was that TNT and selective wait and watch or TME on the basis of tumor response allows organ preservation in almost half of the patients with locally advanced rectal adenocarcinoma without an adverse impact on the oncological outcomes. The sequence of chemoradiation and systemic chemo did not affect the DFS. Delivering chemoradiation before systemic chemo, however, appeared to result in a higher rate of organ preservation compared with chemoradiation after systemic chemo. So this is a summary of all these 4 trials I just mentioned. So in conclusion, over the past decades, the prognosis of patients with LAC has drastically improved, with 5-year pelvic recurrence rate decreased to approximately 5% after implementing MRI, pelvic RT, TME, and chemoradiation. And there is a 3-year DM that decreased to distant metastasis that decreased to 20% using systemic neoadjuvant chemoradiation in the TNT trials, and 3-year OS also improved to 90%. Short course RT and long course RT essentially have similar results with similar oncological outcomes, both increasing the complete response rate. Complete response can further be optimized by prolonging the interval between the end of the neoadjuvant therapy and the assessment, pre-surgical assessment to 6 to 12 weeks. and by administering systemic chemo, that is consolidation chemotherapy during this interval. NCCN currently recommends TNT as a preferred modality in LARC. Although not standard of care yet, 1/4 to 1/2 of patients with locally advanced rectal cancer following TNT and a wait and watch approach could qualify for organ preservation. This requires repeated reassessment in which DRE, proctoscopy, and MRI are all indispensable in assessing the response. So what might be the future? The future perspective could be to use biomarkers before and during the neoadjuvant therapy to assess the treatment efficacy, and immunotherapy combined with chemoradiation to overcome the radio resistance, which can give a higher percentage of complete clinical response, which in turn can help us in deciding whether we should go for TME or a wait and watch approach. So this could all contribute to the future with an individually tailored minimal treatment strategy and a flexibility to adapt as per the tumor response and have minimal impact on the quality of life of the patient. That's it. Thank you, sir.
Thank you, Dr. Sachit, for finishing on time. And before we move on for the expert comments by Dr. Danny and Dr. Atul, I need your help, basically. And maybe if Dr. Shefali can also help me out. I have a friend who is a medical oncologist, and he often teases me that your radiation does not do anything in rectal cancer apart from offering local control, while the overall survival remains same. How do I tackle him? What should I say to him?
You can always say that there is a thing, there is short course RT, which actually is logistically much more preferable for the
He
patient.
says there's no point of giving RT. RT only gives local control. Overall survival remains the same. Why do you want to pester the patient with your radiation?
Sir, even in CT-RT, we are giving RT. In short course RT also, we are giving RT. So there is no question of not having RT in the treatment protocol.
Dr. Shefali, can you just help me out?
Yeah, I would just like to add that we have sufficient evidence that I've presented. So all of which suggests that there is significant decrease in the local recurrence. And rather than later on amending the patient to recurrence and then a salvage modality of treatment, why not prevent it upfront when we can at a minimal amount of toxicity? So that would be my answer.
Thank you. This I'll do. And Dr. Danny Gupta, please for your kindly expert comments. Please.
Yeah, thank you, Abhishek. So I think the concept of neoadjuvant chemotherapy is nothing new. So in all the malignancy, we see urinary bladder, breast, and everywhere in solid tumor, a lot of cancers. Concept of neoadjuvant chemotherapy is coming up. So in rectal cancer, basically, they have coined a new term TNT. Although we were doing preoperative chemoradiotherapy upfront since last so many years, I can say last more than 20 years, followed by surgery and then adjuvant chemotherapy. So only difference what the recent trial have bring up that adjuvant chemotherapy they have given prior to surgery. So they have come up with the idea that if you give all the treatment at one go, so patient is able to complete the full treatment course, because few patients we are seeing that after surgery, they are not able to complete the adjuvant chemotherapy somehow. And with that, they are able to achieve the better preservation of sphincter and better path CR. At the same time, we can select some patients who have complete clinical response based on imaging. We can go for wait and watch policy, depending on if biopsy comes negative. And although they are very highly select patients, and obviously they need very, very strict protocol of doing the follow-up MRI protocol and then proctoscopy and all that. So very select subset we can go for organ preservation. Otherwise, most of the patient needs surgery even after that. So with the benefit of more better sphincter preservation with the complete TNT to go for before surgery. So that's all from my side.
Dr. Atul, anything?
I would congratulate Sachin for excellent presentation. Regarding your first question, how do you tackle the medical oncologist? I think after the introduction of radiation that we were able to achieve more local control in rectal cancer. Previous to that, when the surgery was only the mainstay, there were a lot more local recurrences which were being taken care of by the local radiation. Sir also has enumerated, we were giving adjuvant therapy. Many patients were not able to complete that. And the role of the adjuvant therapy in rectal cancer was also a bit ambiguous. Once we have placed it in front of the surgery, we have been able to fill the gap, the waiting gap also, and we have been able to achieve more PAT-CR. I don't know how PAT-CR is how much a good marker it is, but maybe we'll be able to delineate patients into good risk and bad risk, and uh, these things will help us to take decision. And now we have to choose patients for wait and watch policy also. I think this all area is evolving. We'll be able to delineate patients in whom we need to go ahead with TME, or maybe in patients who need to wait and watch. And again, the MSI high patients, maybe they will be having a totally different treatment with the use of the immunotherapy. Thank
Yeah,
you.
well said by the mentors. And thank you, medical oncologists. Moving on to the last session for today, and I think it should be curtailed one because it's already 8:43. And I request the moderators, Dr. Atul Sharma, Senior Medical Oncologist at JP Hospital, and Dr. Vikas Nayak, Surgical Oncologist, to please take over for the next session. I'll also request the panelists, Dr. Simi Vats, DNB Radio Diagnosis, JP Hospital, Dr. Arnab Chakrabarti, DNB Surgical Oncologist at RGCI, Dr. Mohan Reddy, DNB Surgical Oncologist at Surgical Oncology at Fortis Hospital, Shalimar Bagh, Dr. Shobana, DNB Radiation Oncologist at Max Saket, Dr. Shefali, DNB Radiation Oncologist at RGCI, Dr. Rashmi, DNB Medical Oncologist at BLK Hospital, Dr. Sachit, DNB Medical Oncologist at Dharamshila Hospital.
Good evening. Am I audible?
Yeah, you are.
Can you see your screen, my screen? Yes, sir. Everybody can see my screen?
Yes, we can.
Yes, sir.
Okay. So good evening, everyone. So since you have constraint of time, I'll keep it very short and to a very clinically based discussion. So this is a case of 59-year-old gentleman who was referred to us from a peripheral center with complaints of bleeding PR on and off for the past 3 months. He was already evaluated there with sigmoidoscopy, which showed a circumferential growth at about 5 centimeters from anal verge, and biopsy of the lesion was adenocarcinoma. He had a report of CCT of whole abdomen, which showed a bulky growth in lower rectum, approximately about 6 centimeters from anal verge, for approximately a length of 4 centimeters, with few suspicious perirectal lymph nodes and rest of abdomen being remarkable. CA was 9. So for the panelist, what would be your next plan of action? So is Dr. Arnab.
Sir.
Yeah, so how would you proceed if you come across a patient like this to your OPD? So what would be your approach like?
So I'd like to have something from the history. I should know about what is his family history. The second will be DRE, a detailed DRE, mentioning about the anal tone, anal ring, whether the mass is fixed, mobile, and the circumference. Obviously, the sigmoidoscopy has told it to be a stenotic or circumferential growth. So after completing the DRE, I would like to have a MRI pelvis for a local staging. CT abdomen has already been done. So in the same go, CT thorax should also have been done, or else we'll do it now for the metastatic workup. And So the next will be if the CEA is normal, so there is no need of PET CT. Only if the MRI pelvis shows a extra mesorectal vascular invasion, then only we can go for a PET CT in this patient. That will be my diagnostic workup for this patient.
Okay. So, Dr. Rashmi, is she there? Dr. Shachitanand.
Yes.
Yeah, Dr. Rashmi, yeah. So as a
Yes.
medical oncologist, if you come across such patient, like since
Yes,
for
sir.
surgeons, they are like used to doing DRE and all those tests. As a medical oncologist, if you come across such patient, so what would be your approach like?
So first, for planning the treatment, first I would like to do some test on this biopsy report for EGFR mutations, BRAF, KRAS, and this MSI. If patient is metastatic, so patient would be needing palliative chemotherapy. If all these tests are negative and patient is like locally advanced disease, there's no meds, then I would love to go for PNT first.
Okay. So, that's what I was expecting. Like you straight away went away for the all the advanced markers. So do you really trust the investigation that you come across from the local? Like, for example, I had given you only sigmoidoscopy. So are you happy that only sigmoidoscopy will suffice for this patient? Or
No, sir. No, sir. No, sir. Dr. Arnav has answered. So MRI, pelvis, DRE, everything is like necessary.
A colonoscopy should also be done, sir.
yeah, so that's what I want.
Colonoscopy. Yes, sir.
So this is like you have to tell your plan of action, like whatever may be the other panelist. So like what
Okay,
would
sir.
you do when you are coming across such patient? So so what is the role of colonoscopy? You already have the sigmoidoscopy report. You have the findings. You have all the report needed. So why do you need a colonoscopy?
So synchronous skip metastasis sometimes is there. Some skip
Okay.
lesion also. Yes, sir.
Okay, fair enough. And what about so Dr. Mohan? Dr. Mohan?
Yes, sir.
Yes, sir. So since they have already said, so would you like to do a PET scan for this patient?
As we have not done the colonoscopy, I would like to see on digital rectal examination where my finger is passed beyond the tumor. If there is no obstruction, I will allow for a complete colonoscopy, sir, and no PET CT scan.
So suppose this is the colonoscopy finding at your institution. So they are collaborating the finding of sigmoidoscopy. So the growth is at about 5 centimeters from anal verge, which is similar length of around 4 centimeters. So there are no features of any obstruction, and rest of colon was normal. So what would be your approach like? Like what would you like to do now?
Sir, after the MRI report, I would like to plan whether patient is T3 lesion or T4 lesion. Depending on that, I'll offer neoadjuvant treatment.
So you have a MRI picture. Dr. Simi? Dr. Simi, is she there? Okay, Dr. Arnab?
Sir.
Yeah. So you have done the MRI for the patient. And so what would you like to discuss with the radiologist as a surgeon? So what relevant or pertinent points you need to know so that you can further plan for the surgery from MRI? So since you have already had the discussion on MRI and all, so what points?
The first point will be, as Dr. Simi already told, the distance from the anal verge. Then the T stage of the tumor, the invasion of the tumor into submucosa or muscularis propria or beyond.
Okay.
The second will be the subclassification of T3, ABCD. Whether any nodes, perirectal nodes are present or not. Then I'll go for whether the CRM is threatened here or not. Here it looks a bit to be threatened in this picture. And whether there is an involvement, presence of EMVI, extramesorectal venous elevation.
So when do you label CRM as threatened or involved? Like, is there any definition for that? Like, or
yes, sir. So the CRM is considered to be threatened when the tumor or any node or EMVI is within 1 millimeter, 1 to 2 millimeter of the circumferential resection margins or the CRM. Less than 1 millimeter it comes to potentially positive, we label it.
Okay. So this was our approach. So we had done an MRI pelvis. We did a PET CT as institutional protocol. So there was no distant metastasis. And we had the biopsy slide reviewed also, which showed it to be adenocarcinoma grade 2. So confirming the finding. So with this, we got a clinical stage of CET3N1M0 because there were few perirectal lymph nodes which were suspicious on MRI. So what would be your next approach? Dr. Rashmi.
I'll see patient is like fit for chemotherapy or radiation or not. If patient is fit, I would love to go for TNT.
Okay, so I guess would you like to have a multidisciplinary tumor board discussion before you take the decision? Or
Yes, sir. Yeah.
Okay.
Yes, sir.
Yeah. So, Dr. Mohan. Dr. Mohan?
Yes, sir.
Yeah, so what would be your approach? Like, how would you like to proceed?
Sir, since it is T3 and N1 and circumferential resection margin is threatened,
शायद mute unmute रह गया था.
I would like to go for neoadjuvant chemoradiation, sir, long course chemotherapy.
Okay.
हाँ जी.
So what?
मैंने आंसर दिया भी था, but मैंने बाद में देखा कि मैं म्यूट थी. नहीं याद.
There's some disturbance. Dr. Simi?
हाँ जी मैम.
Dr. Simi?
Yes, sir.
I think you are not mute. So have you joined back?
Oh, sorry, sir. Yes, sir.
Okay. So yeah, Dr. Mohan.
Sir.
Go ahead.
Sir, since it is T3N1 and circumferential resection margin is threatened, I would like to go for a long course chemotherapy.
So what is your aim? Like, what are you trying to achieve?
To get a clear circumferential resection margin so that local recurrence rates can be reduced.
So does Dr. Sachit?
Yes, sir.
So does having a clear CRM have any impact in overall survival rate for the patient?
No, sir. Pathological complete response has an impact on overall survival.
Okay. So would you agree with that, Dr. Arnav? Does having a clear CRM have any overall survival benefit?
Sir, having a clear CRM as of now doesn't have any clear OS benefit. However, the quality of life improves if the CRM is clear, and we can do a sphincter preservation surgery also in that case.
Okay. So we had a MDT review done, and there was a decision to start with new adjuvant concurrent chemo radiation, long course, followed by reassessment for surgery. So as radiation oncologist, Dr. Shobna,
yes. Yes, sir.
Okay, so what would be your approach like for this patient? Like, would you offer this patient a short course or long course? Since we had already the discussion in this thing, so we can just stick to like what you are going to offer for the patient.
Yes, sir. Preferably long course in this patient because the CRM appears to be threatened, and the dose would be 45 to 50.4 gray, rate of 1.8 gray per fraction. With the boost to gross tumor, after 45 gray, we just boost the gross tumor with a little margin around it. And fields would include the entire area of the disease, the rectum, mesorectal fascia, and the drainage pathway of the rectum. The internal iliac nodes will also be included in the treatment along with the mesorectal nodes. And techniques or IMRT is preferred if available over 3D CRT for better tolerance and lesser side effects.
Dr. Shefali, would you like to add anything to it?
Another important thing I would like to add is to optimize the patient before the initiation of radiation, because the patient has presented to us with bleeding per rectum. So it's important to ensure that the HB levels are okay for this patient, because it's also important for radio sensitivity and better response. And similarly, the volumes that have been told by Dr. Shobna, the elective nodes, they would include the internal iliac, then the mesorectal nodes and the obturator nodes, and the mesorectal fascia, the cross disease with a cranio-oral margin of 2 centimeter to the CTV and a radial margin of 1 centimeter to the CTV, and again around 7 mm margin for the PTV. And in my boost phase, I would like to give a direct isotropic margin of around 7 mm. And the preferred technique is definitely IMRT.
Okay.
And also, I would like to have the bladder protocol for this patient to decrease my dose to the OARs.
Okay, fair enough. So suppose if you have the image finding that you have a non-regional lymph node mets, let's say, for example, external iliac, or you have a suspicious node along in the IMA region. So would you like to modify your in this case, if you come across such patient?
Yes. So in such a scenario, we do discuss such suspicious nodes with the radiology team. And if they're found to be positive, we would like to include them in our volumes. So the elective nodal station will then encompass the entire nodal volume. And we would also like to give a boost to the gross disease, gross node, with an adequate margin.
Similarly, the standard protocol of long course RT was followed. So 45 grain, 25 fraction with a 1.8 grain per fraction and a tumor boost of 5.4 grain. So along with this, so we had added concurrent chemotherapy. So Dr. Sachit, so
Yes,
what
sir.
would you like to add as chemotherapy, as a concurrent chemotherapy to this patient?
So there are multiple options based on whether the patient is ready for a daycare treatment or prefers to take an oral chemotherapy. So we can go for oral capecitabine on a daily basis for 5 days per week, 825 milligram per meter square, or go for 5-FU leucovorin at 5-FU 400 milligram per meter square bolus and leucovorin 20 milligram per meter square for 4 days of week 1 and week 5 of the EBRT. Or we can go for continuous infusion 5-FU, which is at 225 milligram per meter square over 24 hours daily on days 1 to 5 for 5 weeks along with RT. So these are the most commonly used options for concurrent chemo.
So Dr. Rashmi, is there any patient factor or any external factors that you consider before choosing the chemotherapy regimen, like for whom you would select capecitabine or for whom 5-FU leucovorin? Is there any patient factors as such that you take into consideration before choosing this chemotherapy regimen?
So mostly, if patient is not willing for daycare admissions, we go for capecitabine only.
Okay. And
Yes.
any other finding? Is there any difference in like the regimen? Like if is like anything better, oral tablet being better than 5-FU from toxicity point of view, or
So,
any?
yeah, 5-FU has more toxicity than capecitabine. Capecitabine is always well tolerated. So
So then why not consider giving capecitabine if it is well tolerated? So why to consider 5-FU? Tell me.
So there is compliance issues also because it's a daily tablet and we won't be under any supervision. The patient will be at home and if there is any kind of toxicity and patient is not actually taking the tablet, the doctor won't be there to supervise that. Compliance issues are there.
Compliance issues. So Dr. Atul, would you like to add anything to it?
I think they both are equivalent. Only difference is there that in patients who have renal impairment, 5-FU will be preferable over capecitabine, because I think below GFR 30, it will be difficult to give capecitabine. I think apart than this, there is no different. I just wanted to know, is anybody considering this patient for total neoadjuvant therapy? Would somebody like to consider this?
Yes, sir.
Yes.
Yes, sir. So according to our institutional protocol, we first go for a short course radiation, followed by 6-cycle capox or 9 Folfox, then again 4 weeks to surgery.
So I mean, we were discussing long course CTRT. However, we can consider him for this total neoadjuvant therapy. Again, we have two different approaches. One is,
yes, sir.
This, I think you just enumerated the rapido protocol.
Yes, sir. Yes, sir.
Okay. So suppose Dr. Shobna, on last day of the radiation, so what advice would you like to give to the patient? Like when the patient comes for the last day of receiving the radiotherapy, so what advice would you give the patient?
So after the last fraction, we usually assess the toxicities within a week or 10 days, the acute toxicities because of because of radiation and chemo. And once all these toxicities settle down, we want the patient to be assessed by a surgical oncologist for preparing the patient for surgery. And patient will be advised to go for an MRI, contrast enhanced MRI pelvis 6 to 8 weeks after the last fraction of radiation. And from that point, based on the findings of the MRI, the patient can be taken up for surgery.
Okay. So, Dr. Shefali,
yes.
to add anything to it?
Yeah, just sort of similar skincare and other dietary restrictions that we have been advising the patient throughout the course of radiation. They need to be continued. So in case of any adverse events, we tell the patient to follow up back with us. And apart from that, then the patient can follow up with the surgeon. So just in case the patient has received short course radiation therapy, that in that scenario, we will not be able to see any acute side effects as such during that point, but they could be present in case the patient is receiving the total neoadjuvant therapy. So in that scenario, we keep the patient in the loop even when the patient is under treatment with a medical oncologist and keep evaluating them on further occasions.
So let's say you have offered the patient short course radiotherapy instead of long course. So when would you like to call the patient back?
So we usually call the patient within a week or 10 days time, and then evaluate for any local skin reactions or any other toxicities. Maybe, for example, the patient can have some skin irritation or some mild diarrhea and all. And in that situation, we do follow up with the patient about 1 week to 10 days. And then also the further follow-up is advised with the medical oncologist then.
And for the surgery part, like what advice would you like to give? Like how many days or how many weeks after short course radiotherapy?
So after a short course radiotherapy, the patient is usually evaluated after 4 cycles of chemotherapy for response assessment with the MRI. And if the patient is responding well, sometimes we do continue with further chemotherapy and then assess again after a completion of 8 cycles. And then the patient in that scenario also reviews with the surgeon as to when they would like to operate the patient.
Suppose the patient is not willing for chemotherapy after short course radiotherapy.
Okay.
In that scenario.
So I think this needs to be discussed with the patient prior to the implementation of short course.
Okay.
So in that scenario, if we have to undergo, the patient has to undergo immediate surgery, then within 7 to 10 days.
So do you prefer immediate surgery or delayed? Because
We
there was a
prefer the
discussion
delayed
by
surgery.
ma'am. Yeah, so there is
We
a
prefer delayed surgery.
yeah. So the delayed approach is preferred over the shorter duration of surgery. So, so Dr. Mohan, so the patient lands up with you after 6 weeks post completion of long course chemotherapy. So what would be your approach like? So you have been referred from radiation oncology. So how would you approach now? What
I would like I would like to do physical examination of the patient once again, sir. Digital rectal examination and tumor assessment. I would like to see the MRI findings. Based on that, I will plan for the surgery, sir. Whether sphincter saving surgery can be performed for the patient or not.
Anything different, Dr. Arnab?
I would like to go for endoscopy also, sir, because a well responsed lesion will show as a flat scar or a white lesion or a presence of telangiectasia also. At that time, clinical complete response can be labeled only after checking endoscopy and MRI findings and forwarding.
So in this case, the patient was followed up 6 weeks post completion of neoadjuvant therapy. So DRE revealed the growth at about 6 centimeters. The bulk of the tumor has, of course, decreased, and the colonoscopy had similar findings. And we had the MRI whole abdomen, which showed significant reduction in the size, 6 to 7 centimeters from anal verge with clear CRM and no significant perirectal lymph nodes. PT chest was unremarkable, and CEA was also within normal limits. So the final post neoadjuvant staging was YC2 M0 M0. So what would you like to do next? Dr. Arnab.
So after this post neoadjuvant chemotherapy therapy staging says YCT2 N0 M0, I'd like to counsel the patient about the surgery and the possible outcomes of the surgery, also counseling about the stoma that may be permanent in up to 10% of the cases. And then I would like to go for an exploratory laparotomy, followed by ultra low anterior resection for this patient. And plus diverting aldosterone.
So, Dr. Mohan, what would be your surgical option?
Sir, I'll go with Dr. Arnab, sir. My option is similar to Dr. Arnab, sir.
Okay. So would you consider, like, will he be a candidate for local excision?
No, sir. No, sir.
Why?
Since T2 lesions, local recurrence chances are high after local excision, sir, for T2 tumors.
And what would be your approach? Like, would you like to go with open, laparoscopic, robotic, or hybrid approach? What would you like to offer to the patient, Dr. Mohan?
Sir, I would like to go for open approach, sir.
Okay. Why?
Depending upon the build of the patient and I'm not sure, sir.
Okay. Dr. Arnab?
Sir, we can go for open as well as robotic approach also, because it has been shown that both of our robotic approach is non-inferior to the open approach. Given it to be a male tumor in a male pelvis, robotic approach can maybe proven better actually.
So the message is like you can approach in any way, whichever you are comfortable with. Even though open is the standard, so you can still proceed with either laparoscopic or robotic, depending on the patient build condition. And as it was said earlier, also in obese patient, they are like laparoscopy is more advantageous. Okay, so depending on your expertise, we can offer any of this approach for these patients. And it has already been shown that laparoscopy is non-inferior to open approach. Okay, there are a few trials we'll quickly skip through. So another important aspect on this is, what is the surgical margin you consider? Dr. Mohan?
Sir, post neoadjuvant treatment, since we have adequate length from the anrectal junction, 2 centimeters or 1 centimeter margin is fair enough, sir. Post neoadjuvant treatment.
Okay. And what about the proximal? Is any relevant?
Proximal is not relevant, sir.
Okay, fine. And Dr. Arnab, so what would be your target margin, surgical margin, distally?
Distally will be 1 centimeter.
And what will be you will be comfortable with CRM margin? How much
CRM 1 millimeter. 1 millimeter.
1 millimeter or more than 1 millimeter, you are comfortable?
Just more than 1 millimeter, yes.
Okay. So this patient had received adjuvant chemotherapy. So what would you like to consider the margin? Will it be pre or post? Because the tumor has regressed. So does that have any impact on considering the surgical margin, distal surgical margin for this patient? Dr. Nab?
Sir, I'd like to go for the post neoadjuvant margin. No, post neoadjuvant tumor status.
That is the purpose, like you're trying to preserve sphincter preservation.
Yes.
And moreover, the shown that, okay, before going into the Dr. Mohan,
sir,
what is your take? What margin will consider?
Sir, I'm not sure about this. Sir. Only since patient is receiving neoadjuvant chemotherapy, I'm not sure about this.
No, you opted for neoadjuvant chemotherapy,
Yes,
right?
sir. Yes, sir.
So you must be having some goal in your mind for offering. Otherwise, you could have, if you wanted that, you could have offered surgery upfront.
Yes, sir.
So what was your goal? So what was your thought process that you are offering neoadjuvant?
Only thought process to obtain negative resection margins and sphincter preservation. Sir.
Yeah, so since your goal is for sphincter preservation, so what margin you are considering now?
Sir, 1 centimeter, sir, same.
So that is the post neoadjuvant margin, right? Post
Yes,
neoadjuvant therapy, because the tumor has shrunk.
Yes, sir.
And it has been shown that post neoadjuvant therapy, the spread, mucosal spread, it is rarely beyond 1 centimeter. So
Yes,
if you obtain a 1 centimeter margin also, the chances of coming later on positive is low.
Yes,
okay. So what about the lateral lymph node dissection? Since these are like surgical topic, so I'm just so Dr. Arnab, do you routinely do pelvic lymph node dissection in CA rectum?
No, sir. The only country to do this is Japan. We follow here. If there is lateral lymph node positive in presentation, after giving NSCT, if this lymph node persists, then only we go for a lateral lymph node dissection, sir.
Dr. Mohan, do you routinely do lateral lymph node dissection?
No, sir.
Okay, so it is not recommended because you are already covering in neoadjuvant as already been said. So internal iliac groups are included. And if any suspicious lymph nodes are present in MRI, so then only you consider for lateral lymph node dissection. Otherwise, it has not shown any benefit. So the pressing point is, what about ileostomy? Dr. Mohan.
Sir, ileostomy rate post neoadjuvant treatment leak rate is around 25%, sir. So I will give the patient the option of ileostomy and I'll do it, sir.
Okay. And Dr. Arnab?
Yes, sir, I agree with him. Getting to be a ISR or ultra low anterior resection, I will perform a diverting ileostomy with this also. Loop ileostomy preferably.
So this question would have come earlier, but still I'll ask you, as taking consent, for taking consent for the surgery, Dr. Mohan, you had said that you will be sorry. So you will be explaining the patient the chances of permanent stoma.
Yes, sir.
What percentage are you looking at?
Sir, it is around 10%, sir.
Okay. Dr. Arnab?
Yes, sir, it's just around 10%.
I request the moderator to please wind up. It's already not.
Okay. Okay, sir. Should I wind up or 2-3 slides, sir?
One question I would like to ask: the post surgery, there is complete path CR. So would you still like to consider patient for adjuvant treatment?
Okay, so it depends, sir. If
anyone can take, Dr. Sachit can take. There is path CR in the surgical specimen, I mean histopathology, would you still like to consider for adjuvant chemotherapy?
No, sir, I would go for surveillance.
Surveillance only, sir.
Okay, this is ambiguous, but they usually say that your treatment plan is based on the baseline presentation.
Yes.
So if you have considered for high risk advanced T3 nodal disease, then it would be definitely part of the treatment plan.
Yes, sir. If TNT is given 6 cycles before in neoadjuvant and 6 cycles after the surgery, it should be given.
So the total plan has to be formulated at the beginning, the
Yes,
baseline.
sir. Yes, sir.
So we usually cannot change it in the middle. I mean, it's good that we had an excellent response. The patient had an excellent response, but better to stick to the plan that we made at the baseline.
Okay, sir.
So,
So I think.
So the final last question I would like. So all the panelists. So is anyone following wait and watch protocol in your institution right now, or actively offering to any patient at the moment? Anyone can.
Yes, sir, we are.
Are you offering wait and watch?
Yes, sir. So in a few patients where we are giving the short course radiation therapy followed by chemotherapy with the total neoadjuvant treatment approach, and if we are seeing a complete clinical response, which is confirmed on digital rectal examination, endoscopy, and MRI. So in that scenario, we do give the patient the offer or the option of wait and watch, and we try to ensure that the patient is compliant and has to be kept on close follow-up as per the protocol. So we do that.
Yeah,
Scenario, well informed to the patient.
Yeah, for Indian scenario, patient compliance, I think, is the most important aspect. Yes. That have to be motivated for constant follow-up. So this is a follow-up, so I can wind up. So over to you, Dr. Abhishek Gulia.
Yeah, Dr. Atul, any expert comments, any conclusions, please?
I would like to thank all the participants, all the moderators, all the mentors who spared so much of valuable time of there and they participated. I think all the presentations, they were wonderful presentations, discussed elaborately. I myself have learned many things, new things. I think this must be a great learning experience for everybody who has been part of this webinar. I would like to thank everybody, and it's already almost 9:30. Thanks and good night.
Thank you, sir.
Thank you, everybody.
Thank you.
Thank you.
Thank you. Thank you, everyone. Bye.